Hi, Siva. We can see you, Siva, on the screen. So if you can start. Okay.
Yeah.
We're just having trouble with Shaq's microphone.
Yeah, sure. Hospital video.
Every day, a large number of people, both children and adults, experience medical intervention and care at M. The Institute of Cardiovascular Diseases, ICVD, at M has many firsts to its credit, including the first adult and pediatric heart transplantation in the private sector, percutaneous pulmonary valve implantation, first bilateral lung transplantation, first Ross procedures, first Batista procedure, and so on. The Institute is made up of several departments, including departments for adult and pediatric cardiology and surgery, and a department for cardiac rehabilitation. It is also home to some of the finest cardiac specialists in India. The Catheterization Lab at the Cardiovascular Diseases Department is a state-of-the-art facility that brings in a multidisciplinary team of doctors. Plus Medical Mission Hospital.
Morning, Shiva. Can you hear us?
Good morning, Shaq. It's nice to nice to hear you. And let us make our first patient's clinical presentation. Dr. Ravindra, my colleague, will present the case.
Let's start. Good morning to all. Warm greetings from M Hospital, Chennai. The first case here is a lady, 35 years old. She underwent pericardial patch closure of AST and PDA ligation at 23 years of age in 2005. Her PA systolic pressure was 80 and mean PA of 48 millimeters of mercury during surgery. No pre-surgery cath study was done. She remained asymptomatic for the next 10 years. She developed dyspnea, fatigue for last 2 years. She has symptoms of pre-syncope, giddiness for last 1 year, and she is diagnosed to have pulmonary arterial hypertension and is on sildenafil 25 mg thrice daily and bosentan 62.5 mg twice daily. On physical examination, she weighs 34 kgs. Her blood pressure is 90 by 70 millimeters of mercury in supine position, narrow pulse pressure, low volume pulse. Her JVP is raised with prominent A waves, no edema, no cyanosis. On cardiac examination, there is cardiomegaly, wide split second heart sound, loud P2, constant pulmonary ejection click, grade 3/4 early diastolic murmur in pulmonary area, grade 2/6 pansystolic murmur in tricuspid area. Her saturation is 98% in room air. Her 6-minute walk distance was 200 meters. The test was not completed. She couldn't walk. She couldn't complete the test. She could walk only for 5 minutes 10 seconds. Her baseline saturation was 97%. Her exercise saturation was 95%. Her NT-pro BNP levels were 1495 picograms per ml. Chest X-ray showed 55% of cardiothoracic ratio, right atrial enlargement, prominent main pulmonary artery, normal lung vascularity. The ECG was right axis deviation with right ventricular hypertrophy with a strain pattern, normal sinus rhythm. Our echo showed systemic venous congestion with RA-RV dilatation and severe RV dysfunction. AST patch was intact, no residual leaks. Moderate TR with peak gradient of 103 millimeters of mercury. Her TAPC was 13 millimeters. Moderate PR with peak PR gradient of 51 millimeters of mercury. D-shaped LV. So the 4-chamber view showed RA-RV dilatation with RV dysfunction. Next. There was moderate TR with peak TR of 103 millimeters of mercury. There was moderate PR, peak PR of 51 millimeters of mercury. The D-shaped LV and a dilated PA was seen. There was systemic venous congestion, dilated SVC. So we planned for a cardiac catheterization assessment followed by hemodynamics and atrial flow regulator implantation if feasible. This is our AFR device. The hemodynamic data was on basal our RA mean pressure was 15 with A of 18, V of 17. RV systolic pressure was 80, RV EDP was 22. PA systolic was 90 with diastolic of 45 and a mean of 60. LV EDP was 20. Aorta was 140 by 90 with mean of 110. Our cardiac output basal was 2.2 liters per minute. PVR was 23, SVR was 43 and PVR SVR ratio was 0.534. On nitric oxide, our RA mean was 16 with A 24 and V 22. Systolic of 80 and RV EDP of 20, PA systolic of 70, diastolic of 38 and a PA mean of 50. LV EDP was 18, aorta was 140 by 90 with 110 of mean. Our cardiac output was 3.17 liters per minute, PVR was 7.12, SVR was 29.6, our PVR to SVR ratio was 0.24. Over to you, sir.
We have this lady who is having a delayed atrial septal defect closure surgically when she was already possibly having pulmonary hypertension in another hospital, and slowly she is now deteriorating with worsening of her pulmonary artery pressures and RV function, and she is getting frequent pre-syncopal episodes. So the indication, the therapeutic options that are available apart from medications like sildenafil, bosentan will be going for a balloon septostomy or single or double lung transplantations. So our plan today will be to,
Okay.
our
So
plan will be
in the
to,
audience, any questions? Nick, is Nick Haas in the audience? No, he's not. Anybody else with, yeah, Joe.
Hi, good morning, Siva. Joe Giovanni here.
Yeah, Joe.
I think it's a good idea. We tend to use stents, and the benefit of stenting is that you can make the hole as big or as small as you want. So, and you're using technology that's on the shelf already.
exactly.
As an alternative.
I think the Birmingham team has already pioneered the diabolo stenting of the atrial septum, and we will just demonstrate this device today. So the intention now, we have already heard the cardiac cath details of significant pulmonary hypertension. So the first step will be to do a transeptal puncture. For a transeptal puncture, we use the routine fluoroscopic guidance. So we advance the pigtail catheter into the aortic root. Yes? Yeah, Dr. Shak.
Teji is going to make a comment.
Yep, please.
Yeah.
Shiva, you already studied for the sildenafil and bosentan
Yep.
already.
Yeah.
Is that patient was responded for that kind of medication?
No, she is.
How is the evaluation
She's-
before and after that?
She's continuing to have pre-syncopal episodes. She continues to have right heart failure with RV dysfunction. There was no significant therapeutic response that was seen with sildenafil and bosentan. We gave a nitric oxide now in the cath lab, and we found that she is a nitric oxide non-responder also. She's basically in an advanced stage of pulmonary hypertension. And
Shiva, you carry on working as well then.
yeah, so what we are planning to do is now a transeptal puncture. So we are currently coming down with fluoroscopic guidance. So the moment we reach just below the aortic root, she has mild scoliosis that you will observe. So now I am hitching against the septum. The next step will be RAO 40. RAO 40. So here we just confirm that.
Now I see that you're not using transesophageal echo guidance at all.
No, not in this patient. So in RAO 40, we are trying to adjust our position onto just being anterior to the descending thoracic aorta, lateral. So the next step will be, this is an atrial septal pericardial patch, a large pericardial patch which is there for the last around close to 20 years. Table up. So here we are targeting the septum between the posterior wall. So now I have entered with my needle into the LA. So now I am advancing my transeptal sheath. I am again checking that I am inside the LA. So now I am withdrawing my needle. Come to AP view. I want the contrast again.
Yeah, Joe Giovanni again. With pulmonary hypertension, sometimes the atrial septum is really bulging towards the left atrium.
Yeah.
And sometimes it's difficult to get purchase on the atrial septum, and when you push it, you're very, very close to the free wall of the left atrium.
Yeah.
Particularly here with a patch, I think most people would use a transesophageal control.
Yeah. Now,
But you've done very well, obviously.
yeah. Actually, the transesophageal echocardiography will need a little bit of sedation. And what happens whenever we give a small amount of sedation for these compromised patients, immediately they become very hypotensive. And so we just intended to avoid an extreme of hypotension. I want a stiff wire now. What I will do is, since this is an...
You could do it with ice.
Yeah, could be done with an ice, yeah, with another venous puncture, yeah, true. I am now withdrawing the wire. I will get it exchanged to a stiffer wire. I will pre-dilate the septum because this patient has got a atrial septal patch which I don't know how it will behave, and so I will pre-dilate with a balloon, and following the dilatation then I will show the
Anybody in the audience used AFR at all? Anybody? Okay, nobody. All right. I know Nick Haas has, but he's still asleep, I think.
We recently we recently sent our data on the AFR to one part of it to JAK intervention and one part of it to CAT CVI. Basically, we have done about 13 patients with pulmonary hypertension, 4 with heart failure, and today we are planning to show you something else also, a Fontan fenestration restriction with this device at the later part of the day. So currently I have got a stiff sheath across, stiff wire across. So now I am going for the recommended sheath for a 10 millimeter fenestration is 14 French. So now I am advancing a 14 French ordinary Mullin sheath.
So in these adults with pulmonary hypertension, do you now just go for a 10 millimeter fenestration, or is there a different format that you use?
In the adults, we go for either an 8 or a 10. In the children, we go for a 6. We never give a 4 because 4 we have found that it might close off very fast. The initial experience from Dr. Joseph Vetukatil when he used a 6 millimeter device was that the fenestrations closed off within a matter of 2 to 3 months. We have been using only 8 and 10 in the adults. We just had one child, a small child, for whom we did a 6 millimeter. Otherwise, most of our experience had been with 8 and 10. In majority of the patients, it is 8. And the patency rate that we are observing at the end of almost 6 to 9 months of our experience, we are finding that almost all of them are patent, with a saturation varying between somewhere around 85 to 90%. During exercise, they desaturate more.
Morgan's got a question or a comment for you.
Yep. Yes.
Shiva, you seem to go across very easily in what could be a challenging anatomy. Do you think you're just across native septum? And also the sheath went across easily, and if you're across native septum or patch, is that going to have an impact on what type of balloon you use, how you bring this up to get ready for the AFR?
Yeah, this was a patient who had a pericardial patch closure, and the place where I punctured, I used a little bit of force, not that it just walked in, but we were able to get a puncture reasonably easily, not with great difficulty. If there is, we don't have gadgets like radio frequency in our lab, and so we will be using, in cases which are having a very stiff septum, we might be using much more harder force from the groin on the broken bone needle. Of course, in those patients, as suggested by Dr. Jode, we might use a transesophageal guidance. So I'll show the device.
So the LVEDP you mentioned earlier was 20. What's the LA pressure at the moment?
The LA pressure now. Show the hemodynamics live. Hemodynamics live. Yeah, the LA pressure currently.
Can't read the numbers. Okay.
Is around 15. 1.5. It's also a little bit on the higher side. In general, in majority of the patients with idiopathic pulmonary hypertension, when we had catheterized, we often observe the LA pressure to be somewhere less than 10. However, this lady had an ASD surgical closure long ago and has got a squashed out left ventricle on the corner, which probably is limiting the filling of the left ventricle substantially. And it may be possible that the bowing of the interventricular septum towards the left ventricle may be elevating the LV end diastolic pressure due to reduction in the volume of the LV. We are getting, this is slightly on the higher side. I want to show the device for you. The right was somewhere around 16, 17.
What's the right atrial pressure as compared to LA pressure?
Mario, when we started the cath, it was...
Mario's got a question for you.
Yeah, I'm hearing that. It was around 16 to 17, but that was at the beginning of the study. If I pull back the sheath into the RA, then I will know what is the RA pressure now. It might have slightly elevated, I feel. At the beginning of the cath, when we were initially placing our catheters, it was 16, 17. So this is the
tell us about the device.
Flow regulator. It has got a shape something similar to a fibula ASD occluder device. It has got 2 discs, and you can see that there is a central waist. This waist varies from 4 mm, 6 mm, 8 mm, and 10 millimeter. And the distance between the 2 discs can be 2 millimeter or 5 or 10. This is a 5 millimeter medium sized device. That means the disc between the left and the right is 5 millimeter apart, and the central hole is 10 millimeter.
And the disc diameter?
The total diameter is, it has got 6 millimeter on either side, so it will be 10 plus 12, 22. So the whole thing will be 22. The central fenestration is 10. So it gets loaded into the sheath.
And the attachment mechanism?
Attachment mechanism is similar to the flex 2 pusher, which is, release it now. So it is similar to the flex 2 pusher that we use for the fibula ASD devices. It has got an eccentric hub here, and now open it. So no, open. Yeah. So the way it is held is, it's an eccentric holding of the device. So now we are going to load the device.
And very briefly, if you could show the handle.
Yeah.
If you can show the handle as well once you've loaded it. Yeah.
Yeah. The holder, the handle is something similar to a fibula, and we lock it by.
Yeah.
This is the locking system, so that as the yellow pusher goes towards the hub, the device gets released. So right now we have flushed it. So we are ready to go into the...
Is the patient on supplemental oxygen right now?
No, there is no oxygen right now. We are not giving any oxygen. The current saturations are just around, it's varying anywhere between 90 to 94%.
So heparinization regime is normal?
Heparinization was done the usual 5,000 heparin. It's roughly about 100, a little more than 100 per kilogram. So here what we do is, the device is now going up into the atrium. We open up the LA disc. Now the central waist is still held within the sheath. Now we pull back till I get my first resistance, and as soon as I get a definite resistance, then I start opening up the device, and the whole device is now opened up. So at this point what I do, I want echo. So at this point what we do is, we look at a contrast echocardiography. The contrast echocardiography is just done by agitating the blood through the same sheath which we are putting in. No, I want a thoracic echo. Yeah, just simple thoracic echo. 4-chamber view. So get the echo.
You don't do any traditional contrast on fluoroscopy, or just contrast echo?
Yeah, saline contrast echo. I will show you now the contrast echo first, and then subsequently I can show you some radiographic contrast also. But this contrast echo basically shows it very nicely. Get a better picture. Get G guy inside. Okay. Yeah. Now you can appreciate the 4-chamber view now. You can see the flow. Are you able to make the echo big for Dr. Mario? Are you able to?
Yeah, we see it.
Yeah. So basically, it's a reasonably vigorous flow, and we can also appreciate now the right ventricular dysfunction. So right now at this point,
go ahead, Gareth.
hands up.
I'm just interested.
Yes, please.
Shiva, can I ask? You didn't pre-dilate
Yeah.
before you put the device in. Are you worried that the center is constricted, and is transthoracic good enough to tell you whether or not you've got a constriction?
We may not get it. Yeah. Now what I will do is I will see the device on fast. Come to caudal. REO caudal. Go caudal. Go fully, nicely caudal.
Normally, do you pre-dilate, Shiva? That's the main question.
Whenever my puncture is through a very difficult portion, then I will pre-dilate. If the puncture is reasonably good, then I don't pre-dilate. What I will do is, see, right now this is the fluoroscopic, make it mag. Right, I'm having a saturation now of somewhere around 84% that I am seeing on the pulse oximeter. See, this is the fluoroscopy. This position looks fine to me, and the amount of desaturation that I'm getting seems appropriate. And so what I'm planning to do is release the device now. What do you say, Dr. Shak?
Are you going to do an angio afterwards, or just?
I can do it now.
Are you going to do an?
I'll do it right now. Come to AP view.
Do you find that you get more desaturation than with balloon septostomy?
Balloon septostomy's problem is a little unpredictable. What we used to do was serial balloon dilatation. We start off with a 68 millimeter balloon, then if you don't get 12, 16, 20, sometimes we end up even using INOE mitral valvuloplasty balloons of close to 26 millimeters to get final orifice of 6 to 7. But this one has given us a lot of ability to you can appreciate a right left flow. I injected 10 ml of contrast, but I think more reliable picture will be on the contrast echocardiography. Once again, Ramya, just contrast echo. In fact, we don't inject contrast.
Siva.
Yeah, echo live.
Yeah, Siva, it's an excellent result. I think a septostomy is out of the question for this because you have uncontrolled desaturation, and particularly in this case, as there is a Dacron patch, I don't think a septostomy is on at all, even if you use a high-pressure balloon. So these things, either a diabolo or this device, give you much better control. Yep. Septostomy doesn't.
Yeah, okay. And when we give a follow-up antiplatelet regimen of aspirin with clopidogrel, we tend to have a long patency. Our longest the follow-up is now a little more than 1 year now, and the patients completely get rid of their syncopal episodes, and they do remarkably less symptomatic in terms of syncope. However, in terms of pulmonary hypertension indicators, right ventricular systolic function, all remain more or less the same. Once again, one final echocardiogram. We now have a right atrial mean pressure of 13. Show the hemodynamics 50% and echocardiography 50%. Show hemodynamics 50. Yeah, we have around 13 to 14. The prominent A waves that were seen originally now all have slightly come down. We can see the now show the echo live. Echo live. So I'm making some of the last. So the
So in the U.S. we don't have these devices, and we're limited to balloon septostomy. Is this reversible? Can you pull it out months later if you want, or can you close it?
We cannot pull it out because it will be get endothelialized. However, it can be closed with another say a muscular VSD device or an ADO2. If it is a smaller device, then we can use an ADO2. But if it is a larger device, then probably we can use a muscular VSD device to close it. we have not had had a situation where we needed to close it, show it better. So we probably feel that it is a closure may not be needed at all, unless if the patient gets into
a couple of other questions, Shiva.
Yeah.
So go ahead, Joe first, and then.
Yeah, you don't have this device in the States, but you can actually use a stent in the atrial septum.
Yeah.
Which the question to Siva: if the hole is small in the device or becomes small, can you actually put a stent within the hole before it closes?
Joe, tell it again.
Question to Siva.
Yeah, Joe. I just tell the question again.
If the hole starts becoming small.
Yeah.
Yeah, if the hole starts becoming small, can you put a stent and does the device expand?
I suppose, yeah, definitely. I think we can definitely put a stent of at least up to 10 millimeter within this, and we have a very clear-cut landmarks, so it is going to be far more easier to put in a stent. We have got a protocol of doing a repeat cardiac catheterization to assess the changes in the cardiac output 6 months after the procedure. In all the patients, we cross the AFR, we enter into the left atrium and record the LA pressures and RA pressures, and crossing is very easy. I suppose putting in balloons and stents and stretching out this is also going to be very easy.
Adam, just for U.S. purposes and Donald Trump purposes, the device is available for compassionate use in the U.S., apparently. There were 2 or 3 questions before we run out of time. Yeah, go ahead, Adam, briefly.
No, I think it's certainly a better way to do it. There's certainly balloon, as you talked about, balloon septostomy, sequential balloon dilation has its limitations. I think the device is probably removable for, even late. A lot of these ASD devices can be pulled out, but like you said, plugging is probably easy.
Thomas, very quickly.
Yeah, very quickly. If I look at your last picture here that we have on the screen, I have the impression that there are 2 different diameters of the tunnel. So it is probably compressed by the septum still. Are the radial forces such that over time it opens up to 10 millimeter completely, or does it remain like this?
There is a possibility that in the native atrial septum there may be further and further opening. However, in a patient with a pericardial patch, I feel that it may not open much more than what it has opened today. We have in some of the patients with pulmonary hypertension, after we have put in the flow regulator, if we observe that the central waist is very much constricted, we used to cross the hole and put in a high pressure Boston Scientific Mustang balloon and try to stretch it out in order to make the device regain its full memory and try to stretch out the atrial septum. In this patient, I did not dilate because the resting saturation has fallen to around 87% right now, and I am happy with the saturations, so I'm not further dilating.
Okay. Paul, did you have a question or? No, that's done. Okay, Shiva, we probably are running a bit tight on time, so are you going to release the device?
Shaq, it's already released. I think show the previous cine.
Yeah, it is.
Yeah, show the last cine, previous cine, just once. So Dr. Shaq, on the other lab there is a very interesting large paravalvar leak which is being closed with an echo navigation, and so that I just want to know at what time you want to come to us. The patient is ready and the leak is just going to be closed. It's going to be done on echo navigation.
Okay, we'll find out in a second whether what we can do in terms of satellite transmission there.
Yeah. Okay.
In the meantime, keep talking.
Yeah.
So you have.
Shaq, actually,
protocol you use? How many minutes do you wait?
Shaq, I think the other mitral paravalvar leak might take another 15 minutes or so, but that is a very interesting echocardiography, and I want to demonstrate
Shiva,
echo navigation.
We'll carry on with the satellite.
Yeah. Okay.
Yeah. So we'll carry on with the satellite. So let's stay live with you if you're quick, and also if you answer
the mitral
question
paravalvar
about protocol.